Let's talk a little bit about clinical outlooks and future directions. What are the biggest challenges in translating these mechanistic insights into real-world clinical strategies for MDS and AML?
So I think the real difficulty here is to try to basically make azacitidine venetoclax better than it is. I think that that's really challenging because is a treatment regimen that works quite well, but the and most of the patients respond quite well. So most of the patients will achieve complete remission. The problem is the relapse, the development of relapse, and then incorporating appropriate treatment in that setting. I think we are moving towards more triplets in at least acute myeloid leukemia and even high risk myelodysplastic syndrome. And there, I don't see many players being able to improve azacitidine venetoclax alone. So for new agents that come, I think the key is to find the right time point to add the specific agent, potentially sequentially, to improve the outcomes. The other big challenge is that this is a very a variable disease. Like you can see some of these leukemias that have excellent responses and some others that we know that are going to become resistant. For example, the disease that I am focusing on, TP53 mutated MDS AML, we know that nothing of the things we have tried over the last decade have worked. So there, we need to find even something that works better than nothing.
Mhm. Interesting. Are there any ongoing clinical trials that specifically address inflammation blockade or microenvironmental reprogramming in resistant myeloid diseases?
So, the disease resistant, I'm not entirely sure, but we know that IRAK1 and IRAK4 inhibitors are being tested with venetoclax in, I think, high risk myelodysplastic syndrome and acute myeloid leukemia. Yes.
How might patient stratification evolve as we integrate inflammatory pathway data and post translational profiles into clinical workflows?
I don't think we are doing that right now. I
Yeah.
think we are far from doing that because I think we need more work to highlight that inflammatory signaling is important. But again, I think there are specific subsets that I would focus on. For example, monocytic leukemias, I would look more carefully on the refractory diseases, the refractory samples, and see if inflammatory signaling is really changed. And the other, obviously, subgroup that there's plenty of room for work on this is TP53 mutated MDS AML. There, I think we can do much better on understanding how inflammatory signaling changes through treatment. Sometimes we have to incorporate bone marrow transplantation there, so see if relapses post BMT are associated with high inflammatory signaling.
Mhm. And we've kind of gotten into this a little bit, but outside of what you've mentioned, just looking ahead, what do you see as the next key experimental questions or technological advancements that are needed to overcome inflammatory driven resistance?
I think the future is obviously in spatial transcriptomics and single cell multiomics to understand what are the source of this inflammatory signaling, because I don't think we understand it very well. Is it indeed the leukemia cells, or basically the mutated hematopoietic cells that they start the cascade, or is something that starts from abnormal bone marrow microenvironment? And again, I think that there could be more than one answers. It could be that the mutated cells start the inflammatory cascade, but I'm pretty sure that alterations of the bone marrow microenvironment are should be described at the more depth.
Wonderful. Well, this has been an amazing conversation.
Thank you.
Thank you so much for joining us on MD Newsline
Thank you.
podcast.
Thank you very much.